So it's my pleasure to introduce our presenter, Dr. Shrivastava. Dr. Shrivastava is a staff neurologist at the Hamilton Health Sciences and McMaster University. He did his medical school, internal medicine, and neurology training at Delhi University in India. His research interests include acute stroke care, quality improvement in stroke healthcare delivery, and neurosonology. And with that, I'll turn it over to Dr. Shrivastava.
Thank you so much, Tina. Let me just begin by sharing my screen. And thank you once again for having me or giving me the chance to do this talk. When I was originally asked to do this talk, I thought, yeah, this should be easy. But then when I started preparing for this talk, there was so much data and information that I thought that I might have to give out, that it became very challenging. So initially what I was going to do was just this part, role of antiplatelets and role of anticoagulants in secondary prevention of stroke, which agents to use, when to start, when do you hold them, and just navigating through the muck that is. But it was getting very drab and very tedious with that. So what I decided was I flipped my talk. And what I thought was I'll do the meat of the talk right up front so that everybody who's here right now and I have their full attention, I can deliver the most important aspects that might be useful to them in patient care early on. And then I can go on and on about all the evidence and the supporting data and the guidelines and why we chose what we discussed about in the initial few slides. So that even if your attention wavers towards the end of the talk, at least you would have gotten what I think is the most useful part of this talk, okay? So when we talk about anti-thrombotics in stroke, it's basically that we are referring to both antiplatelets as well as anticoagulants, okay? So the way I approach any patient with stroke who comes to emerge is to see what am I actually dealing with. Is it a TIA, wherein a patient has a new onset transient neurological deficit attributable to a vascular territory in the brain, but has resolved completely and gone back to his baseline, which would be a TIA, or he has new onset transient neurological deficit attributable to a vascular territory, but has not gone back to baseline and still has some ongoing deficit, which is a stroke. In both those cases, however, the key is once you have a good history, a good exam, good time of onset, all of that initial information is to arrange for an imaging or neuroimaging as soon as possible before you start deciding what you want to do with it. So for the first part of my talk, I'll talk about TIA. So you have a patient who comes in, say, with right side arm and leg weakness lasting about 30 minutes, resolved completely, and now was back to his baseline. You've gotten all his risk factors, you've gotten a good history, and now you're arranging for a CT head and a CT angiogram, arch to vertex, so both of the neck as well as of the brain. And then it doesn't really show up anything on the CT or any well-defined clear acute or subacute stroke. So it confirms your suspicion that this is a TIA. There's nothing on his scan. He's clinically back to his baseline. So what should you do? So what I like to do is look at these patients with these few questions. Part of their workup and assessment is going to happen in ER, and then part of it is going to be they're going to be discharged home, and then the rest of the assessment is going to happen in the stroke prevention clinic. And we want to approach these patients in this stepwise manner. So if we go along this pathway, I don't think so we'll miss out on anything major or treatable, and the patients would be safe, and we'd be doing our best to prevent any more strokes in these patients, despite them having a TIA. So let's take these questions one by one. So as soon as you have a patient with TIA, you've gotten a CT, had CT angiogram, he's gone back to baseline. You have to decide what therapy do you give him acutely versus what therapy you have to discharge him at home. So the question that you have to answer that is, are they already on anticoagulation? So for some reason he's already in no atrial fibrillation or has a PE for which he's on Xarelto or something. So if they are already on anticoagulation and he still had a vascular event, the thing that you must recheck is make sure that there's no stroke on the CT. So there was no stroke on the plain scan, so it is a TIA. The next thing that you check is he on the right agent at the right dose? So a lot of times we have elderly patients who are underdosed on their anticoagulants for no good reason. Or you have somebody who has non-valvular AFib but is still on warfarin because he's just not been to his family doctor in the longest time. So just have a quick look at what medication is he on and is he at the right dose? Is he taking the medications? We've had patients, for example, who've been on apixaban and they say, yes, we are very regular with our medications, but they're taking it 5 milligrams once daily instead of 5 milligrams twice daily. So if he's at the right dose as for the right indication and he's taking it regularly and it's just a TIA, you restart the appropriate agent. So if he was on Eliquis, put him back on Eliquis. If he was on the edoxaban, put him back on it. If he was on dabigatran, put him back on the dabigatran. For any patient with a TIA, when they've gone completely back to baseline and you don't see any major strokes on the CAT scan, you're good to start or restart or resume his anticoagulation at the same day. And you can refer him to stroke prevention clinic, tell him that your further workup will be done from there. He'll need an echo. If for some reason he couldn't get a CT angiogram, he'd need a vascular ultrasound. He will need other risk stratification strategies done, like smoking cessation, or if he needs an anti-cholesterol medication or something of that sort, all of that will be completed. However, if they're not already on anticoagulation, you ask the next question, which is, do they have any indication for any new urgent anticoagulation? So when, say, they can come in emerge, you do an ECG and you find new AFib. Or you have something like this, a CT angiogram that you ordered for the carotids, which suggests that he has a free-floating thrombus in his carotid. So he's gone back to his baseline. There's no stroke on the CT. But he has new free-floating thrombi in his carotids, or he has a known left ventricular thrombus, but he's not on any anticoagulation, or he's a mechanical heart valve, but he's left his anticoagulation for some reason. He's a known DVT pulmonary embolism, and he's for some reason not on medication, or he's non-compliant, so or he's not yet been started. So if you have any of those scenarios, you choose an appropriate agent, and towards the end, we'll see what the appropriate agent for all of these indications will be. Of these, the only indication that you should be a little wary about is a free-floating thrombus, because those are the patients that you don't want to be sending home, even if they have had a TIA and if everything's normal. Those are the patients you want to bring into the hospital, just because they're such a ticking time bomb and anything can happen at any time. And you want to start them on intravenous heparin or something. But for most of the other patients, you can start on the appropriate anticoagulation, choose the right dose, and then refer them to stroke prevention clinic, where again, if whatever tests are pending can be done. So first question, are they already on anticoagulation? If not, do they have any urgent indication for anticoagulation? And if it's a TIA, as I said, you can start them before sending them to stroke prevention clinic. If, however, they weren't already on an anticoagulant, or if they don't have any new indications for any urgent anticoagulation, then you start them on antiplatelets. Now, to decide which antiplatelet to start, or whether you start them on only aspirin, or whether you start them on a combination of aspirin or Plavix, you have to see what their ABCD2 score was for presentation. Now, I'm being very technical here. This is very flexible. A lot of times your ABCD2 score can be low, but you're very convinced it's a TIA and you'd be okay to start them on that. But if we stick these sticklers of guidelines and if we stay very close to guidelines and abide by them, then we must look at the ABCD score. So look at the age, look at his blood pressure, when he was first assessed after TIA, what were the clinical features? Was it only weakness? Was it speech disturbances or was it something else? What was the duration of his TIA symptoms and whether he has diabetes or not? So if anybody on that ABCD score, ABCD2 score has 4 or more, you start them on dual antiplatelets with aspirin and Plavix. Whereas if anybody is scoring lower on the ABCD2 score, you can start them on a single antiplatelet. However, there's a caveat to this. The caveat being the patient should be within 48 to 72 hours of their original presentation. So if you have somebody who had a TIA a week back, he has an ABCD2 score of 6 and he's coming into your emerge for the first time, he's outside the window where you can start him on dual antiplatelets and give him any benefit. He's past his highest risk period and you won't really be giving a lot of benefit to him, but you'll be exposing him to the risks of dual antiplatelets. So, so within 48 to 72 hours, I say 48 to 72 because most of the trials, they actually enrolled only patients up to 24 hours. However, the benefit or the risk benefit ratio was seen up to 72 hours. So if they're within 72 hours and have an ABCD2 score of 4 or more, or if you're very, very convinced it's a TIA, even if it's a lower ABCD2 score, you can go ahead and start them on aspirin and Plavix. Now, whenever you're starting any patient on aspirin or Plavix, you must look at whether they were previously on aspirin or Plavix or not. Because if they were not on any of these medications previously, and you just start them on the regular doses, so you start them on a baby aspirin or you start them on Plavix 75, the effect of the medication is going to, or full effect of medication is going to take at least 3 to 4 days. So if they've come to you in emerge within 48 hours of their symptom onset and you're going to start them on dual antiplatelets, make sure that you load them. So you've given them the aspirin chewable 160 milligrams, or you give them the Plavix 600 milligrams or 300 milligrams, depending on what your risk profile is. Different trials use either 300, which was the Chinese trials, or the international point trials, which are the North American studies. They use a dose of 600. So whichever dose based on the age and other risk profiles of bleeding you're more comfortable with, make sure that you load them on the antiplatelet in front of you. And then you send them home with a prescription of Plavix for at least 3 weeks and then aspirin for this to continue till it's been sorted out in the SPC. And then, of course, patients will be referred to SPC where they'll get their Holters, their echoes. If they, for some reason, haven't had vascular imaging completed, they'll get their carotid ultrasound or something. But if they've had the CTA, they will get it. So that's the third question. If you're going to start them on antiplatelet, what antiplatelet to start, single antiplatelet or dual antiplatelet? Now that's the role in ED. That's what you'll mostly do in ER, and you'll refer these patients to the stroke prevention clinic of your hospital, and then eventually we will figure out what's going on in stroke prevention clinic. So in the stroke prevention clinic, for most patients who've not had imaging, we'll order vascular ultrasound. If they've already had the CTAs, we wouldn't need it. We'll probably get an echocardiogram to see if there's any cardiac source of emboli. And we order a Holter monitor, either a 2-day, 3-day, 2 weeks, depending on our suspicion. And we see if there's any atrial fibrillation that we find. So when a patient comes to us in stroke prevention clinic and we've completed their workup, the next thing that we ask them is there any new atrial fibrillation, or is there any like an obvious cardioembolic source? So they have a left ventricular thrombus or something of that sort. So if you find any new atrial fibrillation, just either on palpation or a 24 to 72-hour Holter, or even in the 2 week, even the 2 week Holter, when we mail it out to them, If there's any atrial fibrillation, we get a call back immediately from mHealth that they look so and so was found to have atrial fibrillation. So you give them a call or you call them back in, you stop their antiplatelets. So you stop aspirin, you stop Plavix, or if you started just one, to stop their aspirin. And for most indications of atrial fibrillation, you will be starting the patient on DOAC, which are apixaban, edoxaban, rivaroxaban, or dabigatran. And if you find something like patient was having rheumatic mitral stenosis that he never knew of, or a detailed workup showed APLA or some other indication where warfarin is still preferred over DOAC, you'll start them on warfarin. But most cases will be eventually DOAC. So that's the first thing that we look in SPC. While the patient is in SPC, we try to prioritize their carotid imaging. If he's already had carotid imaging, then that's good. If he's not, we do an urgent ultrasound of his neck vessels. And we look for, is there any, now the keywords are symptomatic and significant. So by symptomatic, I mean if he has an anterior circulation stroke localized to a left hemisphere. So say he has right arm and leg weakness or language dysfunction, so that localizes to the left hemisphere. Or if he has a right hemispherical stroke, so he had left-sided weakness or some right hemispherical symptoms, and has an ipsilateral significant stenosis. So significant is more than 50%. So if there's any ipsilateral stenosis that's present, which is more than 50%, I will try to arrange for an urgent carotid intervention in these patients. So these are the patients who will be candidates for either an endarterectomy or stenting. And it's a whole different debate which one to choose, but they need one of the two interventions because it is a symptomatic carotid. And the best benefit that you can give for a carotid intervention is within the first 2 weeks, okay? You don't do it super early too, so you don't do it within the first 48 hours, which is what we call the hot carotid, where there's some increased risk of peri-procedural complication, but anywhere from 48 hours to 14 days, and the earlier the better you book them in for either a stenting or an endarterectomy if they have more than 50% stenosis on the side of the hemisphere, which is causing symptoms. So that's another important part of the SPC that you must figure out ASAP is whether they have any significant carotid stenosis or not. However, if they had a posterior circulation stroke or a posterior circulation TIA or ataxia or something as the presenting symptom, then that wouldn't, even if you find some stenosis in their carotids, then that's really not symptomatic. So the keyword is to be symptomatic and significant carotid stenosis. Now, once you've done the SPC workup, the next thing that you're going to do is figure out what caused the stroke. So until date, the best way to look at what the stroke etiology is to go back to what we call the TOAST classification, which is large arterial atherosclerosis, cardioembolism, small vessel disease, cryptogenic, or other determined etiology. So large artery atherosclerosis is if there's a symptomatic stenosis either extracranially or intracranially. Extracranially more than 50% in the ICA, so that automatically is a candidate for surgery, or intracranially more than 50% stenosis in any of the territories or any of the vessels which is supplying the impacted territory or the TIA territory. So that's large artery atherosclerosis. Whenever you have a patient for large artery atherosclerosis, if it is more than 70% stenosis intracranially, you can start these patients on DAPT, which you continue for 3 months. This is again debatable, but I'm just giving you my approach. There's a lot of controversy around whether single antiplatelets versus dual antiplatelets. There's no good evidence. There's some trials which are ongoing to answer this question. But my current approach is if I find 70 to 99 intracranial stenosis, I'll do DAPT for 3 months. However, if there's 50 to 69% stenosis, I'll just do the aspirin. And depends on if they've had a 21-day course of dual antiplatelet. That's based on their ABCD score and their time of presentation. This is further long-term therapy. So if they are 50 to 69% stenosis, single antiplatelet. Similarly, if you have vertebral artery stenosis or a non-stenotic carotid disease. So I think he has an ugly plaque in his carotid. And I know that that was responsible for his stroke. It's less than 50%, so he's not a candidate for any intervention. So I'll just do, maybe after the initial 3 weeks of that, I'll just do single antiplatelet right now. Small vessel disease. Small vessel disease is when you have lipohyalinosis of the terminal perforator vessels, or you get the deep lacunar strokes from this. Again, no great evidence. We have some subgroup analysis of our major stroke trials, which suggest maybe there's some benefit of antiplatelets to them, but I would continue these patients on single antiplatelets. There are some things like salostazole, which is not really available in Canada, which might have slightly more evidence for small vessel disease. For cardioembolism, I already said, if you have an atrial fibrillation, new or LV thrombus, you have a new diagnosis of urgent anticoagulation, start them on the appropriate agent, or if you have a known mechanical valve and the patient wasn't really taking his medication, so start them back on their medication. If you have an other determined etiology, say if your CT angiogram showed dissection, or if you have some, your workup reveals a PFO or something of that sort, you treat for that specific etiology. And if your initial Holters are negative, your CT angios are negative, it's not a small vessel disease, it's not a deep lacunar stroke, they fall into this diagnosis of cryptogenic strokes or ESUS, embolic strokes of undetermined source. Again, we had a lot of data trialing antiplatelets versus anticoagulants in them, and we found out it's only single antiplatelets that are beneficial for long-term stroke prevention in all of these cryptogenic strokes. So that is my approach to anti-thrombotics, or that's antiplatelets and anticoagulation in TIAs. A very similar thing happens when a patient comes to an emerge, but this time is a stroke. So he has new onset transient neurological deficits, but his deficits are persisting and it's not back to his baseline. You arrange for an urgent CT head, CT angiogram, you page stroke overhead, and here the question that you're really answering is something different. The first question here that you're answering is, are they candidates for any urgent reperfusion therapy? So are they candidates for TNK? Are they candidates for EDP? And if not, for whatever reason, then comes the question, what antiplatelets to start? You note that here the urgent anticoagulation indication is below. That's because if you had ongoing deficits, it would be seldom, if ever, that you'll be starting them on anticoagulation immediately, because any patient who's had a stroke and maybe you've not even been able to see the size of stroke on CAT scan, it's not yet seen on CT, but he has ongoing deficits, you wouldn't be comfortable starting them on anticoagulation immediately. You'd wait a couple of days, or at least till a repeat scan shows the size of stroke. And in the meantime, you'll just start them on antiplatelets. And then you start looking, get these patients admitted to the stroke unit, and then you start looking at the same questions. Do they have any known new or urgent need for anticoagulation? Is there any significant ipsilateral carotid stenosis? And what is the stroke mechanism? So the first and foremost step, however, is going to be, are they candidates for reperfusion? So if they're in the window, they have disabling deficits, they'd be candidates for TNK. If they have a large vessel occlusion, they're still within 24 hours, they'd be candidate for mechanical thrombectomy. Now, any patient you've done mechanical thrombectomy on, or if you've given them TNK, no matter what they were on coming into the hospital, they could have been on anticoagulation, they could have been on aspirin, they could have been on Plavix, they could have been DAP. You hold everything for 24 hours. Okay, in even DVT prophylaxis, pharmacological DVT prophylaxis, you will do intermittent pneumatic compression instead of pharmacological DVT prophylaxis. And then you repeat a CT head in 24 hours, see the size of stroke, and make sure that there is no hemorrhagic transformation. So to look at hemorrhagic transformation, we use what we call the Heidelberg classification, whereas We have hemorrhagic infarct type 1 or HI1, which is basically this tiny petechial hemorrhages in the area of the stroke. Or you have an HI2, which is hemorrhagic infarct type 2, which is basically a more confluent petechiae in the area of the infarct. HI1, HIT, and most cases of HI2, you would be okay to start a single antiplatelet agent aspirin. For HI1, you're also okay to start pharmacological DVT prophylaxis. Maybe for HI2, you might hold on to pharmacological DVT prophylaxis for another 48 hours and keep them on pneumatic compression. However, the moment you see PH1, which is parenchymal hematoma 1, or PH2, which is parenchymal hematoma with mass effect, so if the moment you start seeing PH1 and PH2, you'll probably have to hold antiplatelets or anticoagulants for at least 48 hours, if not longer, maybe even up to 7 days to 14 days, depending on whatever is the size of the PH1 or PH2. However, if there's no hemorrhagic transformation, or as I said, HI1 or at most an HI2, you can start single antiplatelets. And then at least in an HI1, you'd be able to start DVT prophylaxis as well. If there's no hemorrhagic transformation, you're good to start both. And then you carry forward. However, if these patients are not candidates for an acute intervention, so they're not candidates for TNK or EVT, for whatever reason, they may be out of window, they may have non-disabling deficits or something, then you look at their NIHSS scores and you see how bad is their symptoms. Is it like looks like a minor stroke, which is an NIHSS. This is a random definition, but it's just for helping guide therapy in general. We must always correlate it with what we see in CT. So if an NIHSS of 5 or less, you would be mostly safe to start these patients on dual antiplatelet therapy. And again, they should be within 48 to 72 hours of their symptom onset. And as I said, there should be no moderate. So sometimes you can have a large right frontal stroke, which is in a non-eloquent area, and his NIHSS would be less than 5, but those won't be the patients that you would start on dual antiplatelet. Those will be patients that despite their low NIHSS, you would be doing single antiplatelet because of the large infarct size that you see on CT. Whereas there will be patients of NIHSS 6 or higher, which you will, even if there's a small stroke that you see, you would probably restrict them to single antiplatelets until and unless you are very concerned for some reason that you want them to be on dual antiplatelet. Or as I said, if you see a moderate to large stroke, you'll likely keep them only on single antiplatelets, or if it's been more than 72 hours of stroke onset symptoms, again, you're likely to keep them on single antiplatelets. So a slightly different approach as compared to TIA, where we were looking at the ABCD2 score. Here we are looking at the NIHSS or the stroke that we see on CT to decide our antiplatelet therapy. And the one key thing is we don't start anybody who has ongoing deficits, we don't start them on anticoagulation immediately. Maybe the only exception to that rule would be somebody with a free-floating thrombus, which I said is a ticking time bomb. But for most other patients, you'd probably at least wait 24, if not 48 hours before you put them on anticoagulation. So the next steps are somewhat similar. So these patients would be admitted to a stroke unit, and if there's any known or new or urgent need for anticoagulation, then you estimate the stroke size on CT to decide when you can start these anticoagulation. So if it's a small stroke, say this one's just in the thalamus, this would be good to start anticoagulation in 48 hours alone. However, if you have a slightly bigger or a moderate size stroke, you should be looking at somewhere between 2 to 7 days. And if you have a still bigger stroke, like a whole large MCA territory, I think 10 to 14 days is the way before which you wouldn't be comfortable in starting the anticoagulation. Now, there is some new data which suggests that starting anticoagulation in these patients earlier might be safe. And in which case, I'll talk about it at the end. On a case-by-case basis, you might consider for early anticoagulation, but by and large, we stick to this broad guideline There are some other guidelines like the 1-3-6-12 rule or something which you can use, but by and large, we stick to this broad guideline. And then again, we look for any symptomatic ipsilateral carotid stenosis. And if you find, say, if you have high-grade carotid stenosis, you will refer these patients urgently for carotid endarterectomy or carotid artery stenting, depending on for various factors. And then again, you look at the same thing. What is the stroke mechanism? Is it large artery athero from intracranial atherosclerotic disease, or is it small vessel disease, or is it a cardioembolic stroke once your workup's complete, or is it any other determined etiology, or is it cryptogenic and you decide your antiplatelet therapy based on that. Some general rules to remember is before we load them with antiplatelets or give them any oral medications, you must make sure that they're able to swallow safely. So we do the screening test for acute neurological dysphagia, or the STAND screening, and make sure that they're able to swallow. If they're not able to swallow, aspirin can still be given rectally, but Plavix or ticagrelor, you don't really have any options for anti-platelets or parenteral routes in those patients. So you'd likely be choosing a single antiplatelet. If for a TIA patient, you're going to start them on anticoagulation, I always look at their blood pressure. If the blood pressure is like 220 over 110, or if they have like active bleeding in their GI tract or genitourinary tract, I would avoid early anticoagulation. If for all your stroke patients who you're just putting on antiplatelets, make sure you're looking whether they need DVT prophylaxis, either pharmacological or intermittent pneumatic compression. A lot of times the family, sorry, this is a typo. So a lot of time family will say, no, our patient is falling too much. You're going to start them on a blood thinner. Will it be safe? Will they have like a bleeding or SDH? And this question has been addressed multiple times. The risks of intracranial bleeding from a fall versus benefits of anticoagulation in a patient with AFib to prevent stroke. The benefits outweigh the risks. So you can reassure them that the benefits would outweigh the risks. And then one general rule that we must always remember is, if say you found one etiology, don't stop looking for other etiologies. Say the patient comes in and you have new AFib and you found AFib and you started on anticoagulation. It doesn't mean that you will not image his carotids. What if he has an ipsilateral significant carotid stenosis at the same time? So that you're going to treat that as well, right? At the same time, say if you have a patient with significant carotid stenosis and you've referred him for carotid endarterectomy, it doesn't mean you'll stop looking for AFib in that patient, because they may have two coexistent mechanisms of stroke. So always look for all possible etiologies and always treat for all possible etiologies. Now, so that was the major chunk of what I wanted to tell you. And instead of doing at the end and rushing it away, I wanted to do it at the start so that I can give you one general broad brush strokes of everything. From now on, maybe for the next 10 to 15 minutes, I'll just go quickly over the various antiplatelet agents, maybe give you some important, interesting tidbits about them. But these ones are like, you'll have my slides, you can have copy of them if you ever want to refer back to. But this is more of a general information rather than anything specific. The major chunk was what I wanted to talk to you in that. So for the various antiplatelets, we already know most of them work through inhibiting platelet activation, either aspirin, which works on the COX-1 enzyme to inhibit thromboxane A2, or all the P2Y12 receptor inhibitors like clopidogrel or ticagrelor. Or we have the latest generation parenteral ones, which inhibit the GP2B3A1 receptors. We have a lot of antiplatelets, but our go-to is always aspirin. As I said, if you give the chewable aspirin, the effect starts within 1 to 2 hours, lasts, even if you miss a dose, it will be irreversible. Acetylation will last a few days. The original evidence for aspirin efficacy came way back in 1997 through these two large IST and Chinese acute stroke trials, wherein there was about a pooled analysis showing significant reduction of 11 recurrent strokes or deaths per 1,000 patients. So a number needed to treat of about 79. So not the best, but at least something better than nothing. This was the original antiplatelet that we had. Then we had clopidogrel. Clopidogrel, the only issue is it needs activation to undergo into its active metabolite in the liver through a CYP2C19 mechanism enzyme, which gives it some heterogeneity. Say if you're heterogeneous or if you have a mutation which really you're a slow metabolizer of clopidogrel, then you are in for trouble because you might not be having the same antiplatelet efficacy as compared to aspirin, which is more independent of these genetic variations. Again, if you load these patients with the right dose, the full effect is within 2 to 4 hours. And the original efficacy for clopidogrel came from the CAPRI trial, which showed there was slight benefit of clopidogrel over aspirin. However, that was mainly driven by peripheral arterial disease, not in strokes or MIs. So overall, we still choose aspirin. It's easier. It's over the counter. There's no genetic polymorphism in aspirin. So it's just a more go-to medication for always for stroke. The CYP2C19 enzyme mutation can be seen in as many as 30 to 50% of East Asians, about 20 to 30% of South Asians, about 20% of African Americans, and about 15% of Caucasians. So it may be some concern for giving Plavix in these patients. Then you have another medication which acts on the same receptor, which is new and upcoming, which is ticagrelor, which is really very commonly used in the cardiology world, which doesn't need to be activated. So it's directly in the active form. It doesn't really need to be activated. And you can always use that whenever you're suspecting clopidogrel resistance. We have evidence from the CHANCE-2 trial that DAPT with aspirin and ticagrelor might be better than aspirin and Plavix in those patients with the CYP2C19 mutation. The original benefit data we have from the Socrates trial. I'll skip all this. Agrinox was very popular a while back. It's no longer that popular because of some of the side effects like headaches and GI disturbances. But this is aspirin and sustained release dipyridamole, which is a cyclic phosphodiesterase inhibitor, increases cyclic AMP levels in your blood. A lot of trials explored its efficacy compared to placebo as well as compared to aspirin. Maybe again, slight suggestion of benefit as compared to aspirin alone, but the side effects don't really warrant us to give Agrinox as compared to aspirin alone. Then all the dual antiplatelet stuff that I was talking about in TIAs or minor strokes, all that comes from these three major trials, which is the CHANCE, which showed in 2013 aspirin and Plavix versus aspirin alone, risk of stroke is much less if you are on the dual therapy. Similarly, POINT in 2018 showed the same thing. If you had aspirin versus aspirin and Plavix, you would be the risk of aspirin with aspirin alone, the risk of strokes are higher. With aspirin plus Plavix, the risk of recurrent strokes are lower. All these trials gave antiplatelets for 3 months, but what they really saw that after the initial 3 weeks, there's not a lot of benefit that you're doing. See, these are almost parallel curves, and there's an increased risk of bleeding that's happening. So that's why we switched our guidelines to just do it for the 3 weeks. And then same with aspirin and ticagrelor in the THALES trial, all that benefit is upfront, whereas the risk of bleeding is after the first 21 days. Briefly, this is where we are heading to, and then we found through the COMPASS trial that if you have patients who have stable coronary artery disease or peripheral arterial disease or asymptomatic carotid artery disease who you're going to trial medical management, if you try these patients on both aspirin as well as a low dose of an anticoagulant, which is Riva, Roxaban 2.5 BID, there's about a 50% stroke risk reduction. And then similarly, there are ongoing trials for factor 11 inhibitors in addition to antiplatelets, of which we'll know the results soon. Um, Anticoagulants, we all know the CHA2DS2-VASc score, but anybody who's had a stroke automatically qualifies for anticoagulation lifelong. Has-blood score is not the most useful, but it just gives you an idea whether you're going to be dealing with somebody who's likely to bleed. Um, and then most of the anticoagulants that we have are targeting the factor 10A in the coagulation cascade, which is the apixaban, rivaroxaban, edoxaban, as well as direct thrombin inhibitors such as dabigatran that we have. The warfarin, which is old, acts through depleting factors 2, 7, 9, 10. We had the old data from WARS or WASID, which really showed that there was about a 64% risk reduction in AFib. DOACs came the new trials, the Aristotle, the Averroes, the Engage, IMTIMI, the Rely, and the Rocket trials. All these trials showed the benefit of these DOACs, which were like apixaban was superior to warfarin in preventing stroke. Edoxaban and rivaroxaban were non-inferior to warfarin in preventing stroke. Dabigatran 150 was superior compared to warfarin for preventing stroke. And then all of them were safer because they had reduced ICH, and dabigatran was as safe as warfarin. So based on the convenience that we didn't have to do PTINR monitoring, we didn't have the risks of ICH, the whole world switched to DOACs for atrial fibrillation, except very few conditions where you still have to resort to warfarin, such as if you have rheumatic mitral disease or degenerative severe mitral stenosis, or if you have mechanical heart valves in any location, or if you have an APLA syndrome, or if you have a LV thrombus, or if you have a patient who's pregnant, because you can't really use DOACs or warfarin in these patients. And then it was an initial concern previously, patients with end-stage renal disease. However, apixaban is now proving to be equally safe and effective, if not more safe than warfarin in these patients as well. And then, like, there are some patients who don't have drug coverage, who can't really afford DOACs, who can always go on warfarin because it's safe. So, because it's still effective and it's much more cheap. So there are some cases that you'll prefer vitamin K antagonists over DOACs. I spoke about timings of initiation after stroke, the 1-3-6-12 rule, which was what we usually commonly use, or the 4 to 14 days. That's the American guidelines. However, as I said, there's this new trial, which is known as the ELAN trial, which trialed early initiation in minor to moderate stroke at about 2 days, whereas in major stroke at about 6 to 7 days. And it showed that it was equally safe, if not superior or inferior. So maybe we are heading towards early anticoagulation. Few things about some of the anticoagulants. Dabigatran, it's no longer as commonly used because of its GI side effects. But remember that it should only be dispensed and stored in the original bottle with desiccant or a blister package, and it cannot be crushed. Apixaban, all of these have, like, if you go on Thrombosis Canada, you'll always find the dose that it's commonly used, and if there's any indication for reduced dose. Apixaban is by far the most safest and the most efficacious that we have. There's rivaroxaban. You must remember that it has to be taken with food. So if you have a patient who's not taking with food, rivaroxaban absorption is about only 60%. And then edoxaban again, reduced kidney function, extremes of age, body weight, all of these are reasons that you might have to reduce. But whenever you're in doubt, just go to Thrombosis Canada website and figure out what is the actual dose for your patient. And then just to summarize everything that we spoke about, your by and large long scheme of things is going to be dependent on what your stroke or TI mechanism was. If you have non-valvular AFib, you're going to do DOACs. If you have valvular AFib, it's going to be warfarin by and large. If you have an LV thrombus, again, warfarin. If you have a PFO, I didn't go into specific etiologies, but PFO, you need closure. cryptogenic strokes, you still just do single antiplatelet. For extracranial atherosclerosis, if it's more than 50%, you revascularize with either stent or CEA. Intracranial atherosclerosis, more than 70%, you do DAPT, but less than 70%, you do just single antiplatelet. And with that, this was just trying to condense everything into one talk. I'll stop sharing my screen and then I will take up questions and see what's going on. I'm sorry I had to rush through towards the end, but a lot of the things that I spoke towards the end, you'll find in literature. The thing that I wanted to stress about was my approach when I see a patient, which I thought might be more beneficial. Okay, I see one question in the chat for free-floating thrombus. So for free-floating thrombus, the acute, as I said, you need to bring these patients in, start them on intravenous heparin, titrate it with the nomograms, and then you start to repeat imaging them in 2 to 3 days, repeat a CT and just see that free-floating thrombus gone, dissolved, or is it still persisting? If it has not dissolved, maybe 1 more week of heparin you might try to see if it's resolved. If it's resolved, then you go back to dual antiplatelets or single antiplatelets, depending on your stroke size and other mechanisms and everything. However, if it's still not resolved after maybe say 7 to 10 days of heparin, you might just want to switch them to long-term anticoagulation with warfarin for 3 months, repeat the CTAs in 3 months, and then see what's going on.
There's a couple of more questions, Dr. Shrivastas. 2 questions. Same loading dose for dual antiplatelet therapy and symptomatic ICAD?
Yes, absolutely. And the loading dose is irrespective of the etiology. The loading dose is because you want the action to come in ASAP. I use the 160 and 300 just because the 600, sometimes you have an elderly patient, might be at risk, predisposing them to some GI bleed risk. But if it's a very high-risk patient who's having recurrent TIs and I want the action like that, I would go with the 600 loading dose for Plavix and 160 chewable aspirin.
Great. Next question. What to do if the patient with a recent TIA on DAP comes in with a stroke? Continue the same DAP or switch?
So if they come in with a stroke, you go down the stroke pathway. You first look at, are they revascularizable candidates or not? Can you do a EVT or TNK for them or not? If you cannot, the recommendation is to continue with the same DAP unless you have suspicion, say, are they of East Asian descent? Are you suspecting clopidogrel resistance in them? Or the patient was super compliant and still had something. Maybe those are the cases where you might want to consider aspirin and ticagrelor instead of aspirin and Plavix. However, that won't be evidence-based. It will be a hunch because we don't have like ready-made genetic testing for CYP2C19 available in our ERs. It's a point-of-care test that was used in the CHANCE-2 trial in China, but we don't have it so far. And I don't know if the cost-benefit ratio will ever justify us getting that in ERs, but yeah, if you have a strong suspicion that they still had the stroke and they're not revascularized candidates, and they still qualify for that, maybe you can think of ticagrelor instead of Plavix if you have a suspicion fair enough for resistance for these patients.
Great. Another question. In community emergency departments, there's some resistance to doing CTA. Should we advocate for CT and CTA to be standard in the evaluation of TIA?
It should be. I know there's a lot of resistance, and we are, at least most of our centers that we like, at least at HHS and St. Joe's and Jerovinsky, I think by and large we are okay to get CT angiograms like 9 out of 10 times. But so I go back to what one of my teachers, he always used to tell me, stroke is a plumbing issue. If you don't look at the vessels, you don't know what's the problem. You might miss a free floating thrombus, you might miss a dissection, you might miss very ulcerative plaque which is just about to thromboembolize. So if you don't really look at your pipes in a plumbing issue, that's not good care for the patient. So yeah, I think it should be standard. I think if we as a group really band together and make it, I think it's achievable. I think it should be like CTA should be standard.
Great. Follow-up question. Also, if carotid ultrasounds have to be used, what is the timeline we should aim for post-presentation to the ED?
I think it should be as early as possible. If you can't do a CTA, then try to get the carotid ultrasound in the next 48 hours, or send them to a stroke prevention clinic, which does not have a long wait time, and they can see the patient immediately, maybe by day 2 or day 3, so that most stroke prevention clinics would be able to do an urgent carotid the same day. And if they find a carotid which is significantly symptomatic, they might just get the patient in for vascular surgery or something. So I would say within 48 hours if you're doing it on your own, or just best would be just to refer them to a stroke prevention clinic, which does not have a lot of delays in seeing their acute strokes or acute TIAs.
Okay. Sorry. Next question. For MCA stroke plus same-sided carotid stenosis 70%, what is the ideal time to do a CEA? And then what is the risk of recurrent stroke while waiting for the CEA?
Yeah, if it is the ipsilateral carotid which has caused the stroke, as I said, there's some evidence which suggests if you do a CA within the first 48 hours, there's some increased peri-procedural complications. So we don't really touch a hot carotid. But once it's been 2 days, then you start pestering a vascular surgeon and do it as early as possible. They usually still take about 1 to 2 days. So I start pestering them by day 1 itself, so that they have them on their board and they can reach them as soon as the 48-hour window is out. But in any case, the maximum benefit you're going to get is within the first 2 weeks. So it should never be delayed beyond that. And after the first 2 days, it should really be as early as possible. There is always a risk of recurrent strokes while you're waiting for CEA. So that's why you appropriately treat. So if it is a significant carotid which is causing the stroke and he doesn't have already a large stroke on the CTA, on the brain CT or brain MRI, I would do dual antiplatelets to reduce that risk. But of course, there is always that risk of recurrent stroke. I think it might be in the initial few days, even up to the tune of 4 to 5% if it's a symptomatic carotid. But just because the upfront peri-procedural risks would be so high if you do it within the first 48 hours, that it's not justified. So anytime after day 2, as early as possible.
Okay, thank you. Yes, and it was noted that the etiology for the stroke was large artery atherosclerosis. So,
yeah, so
yeah.
extracranial large artery atherosclerosis is when you refer this CA urgently.
Okay. Oh, I see there's, thank you. And here's another question here. I've seen patients started on DAPT for non-proven indications, such as low-risk TIA or high-risk stroke. What would be best course of action?
Yeah, as I said, when I was saying that a rough guideline, it's not hardcore, or like a strict indication. I would usually do only if it's an ABCD2 more than 4. But say if you had a very convincing amaurosis fugax, the ABCD score is going to be low, and I would still probably do that in those patients, even though it's a little outside guidelines, just because if I've seen the carotid and I know that there's an ulcerated plaque there, I have a very high risk of having a stroke in the next couple of days till I get that carotid sorted, till I get that patient a stent or a CA. So as I said, these are guidelines. These aren't hardcore absolute that we have written down in stone, carved in stone. But by and large, I would do it for ABCD2 more than 4. Low risk TIAs. The problem with the low risk TIAs are they can so often be mimics. Like they can be seizures, they can be confusion, UTI, like they can be and you're subjecting them to some GI bleeding risk or some actual serious bleeding risk by giving them that. So that's why they don't really recommend for a low risk TI. For a if it's a deficit which is persisting, so it is a stroke, then I go by the site of the stroke, what I see on CT, and what the NIHSS is to decide that.
Tina, there's a question for you. Any chance we can get the presentation slides? I know that you typically will send those out. I don't know if you want to respond to that.
Yes, so I was going to type. I'm typing an answer, but I will include the link because we don't have everyone's email. So it will be on the website. And so the link is there where we have later this afternoon. So once we have the recording up on YouTube, then I'll put the link to the recording and the slides. Okay, so there's just a minute or two left if anybody has any last questions, and feel free to unmute if you'd rather do it that way. Okay, so maybe we'll just give a minute and okay. Well, the YouTube channel name, I'm actually not sure of the YouTube channel name. So the link will be on the website. But if you email me, I can send you the name, the direct name. Oh, sorry. As well. Okay. So I just wanted to let everyone know that we do have one final presentation coming up on December 6th at noon. Dr. Joundi will be speaking on stroke recovery trajectory and prognostication. And it will be the same Zoom link and meeting ID as you used today. Okay, so it's 12:59. We've got some thanks in the chat. So thank you very much. Excellent presentation, lots of information, and really very well organized. It's easy for to follow along. And thank you to the audience for your questions. And you've got the links that you needed in the chat. For the certificates and for the evaluation. And as I said, the recording and the slides will be available on our website by this afternoon. Okay, so I want to wish everyone a great afternoon and see you next time. Thank you.